They lied to us, or at the very least, they paid handsomely to bend the story. In the 1960s, the Sugar Research Foundation secretly funded Harvard scientists to publish a highly influential review that shifted blame for heart disease away from sugar and onto saturated fat. The funding and industry role was not disclosed. That review helped script decades of low-fat dogma that many of us dutifully followed, even when our patients didn't get better. So today, let's do what good clinicians and patients do. Look back with clear eyes. A new systematic review and meta-analysis of randomized controlled trials, the gold standard, asked a simple question, a humbling question. Does restricting saturated fat actually reduce heart attacks, cardiovascular deaths, or all-cause mortality? The authors pulled 9 RCTs with 13,532 participants. The results: no significant difference in cardiovascular mortality, all-cause mortality, myocardial infarction, or coronary events between the saturated fat restricted groups and the controls. Stroke couldn't be evaluated because there weren't enough events. Their bottom line: based on RCTs, routine saturated fat restriction cannot be recommended to prevent cardiovascular disease or death. Let that sink in. Decades of fear, millions of low-fat products, a generation of patients avoiding egg yolks like they were smuggling contraband, and the randomized trials don't show a benefit on the outcomes we actually care about: living longer and avoiding heart attacks. We lowered fat. We didn't lower events. That's not nutrition theater. That's a signal clinicians cannot ignore. Now, to be fair and scientific, history is messy. Some historians push back on the sugar shifted all the blame narrative. Science evolves, and there's debate about how much the sugar industry truly tilted the table. But even if you grant that debate, it doesn't change what the randomized trials say about saturated fat restriction and hard outcomes. What's the point? Evidence should lead the way, not marketing, not vibes, not yesterday's headlines. So what do we actually do with this? First, we stop worshiping proxies. LDL total cholesterol can go down while your outcomes don't budge. I care about people, not just panels. If your protocol improves a lab but doesn't move mortality or MI risk in trials, I'm not hanging my stethoscope on it. Outcomes are greater than optics. Second, we go root cause. Most of my patients don't get sick because butter ambushed them in a dark alley. They get sick because of hyperinsulinemia, refined sugar, and ultra-processed carbohydrates that hijack appetite, inflame the system, and push the liver toward fat storage. The sugar papers remind us how industry narratives can distract us from causes that actually map to patient outcomes. If your daily diet is a parade of added sugars and refined starches, your triglycerides climb, your HDL sinks, your belly fat expands, your blood pressure rises, your sleep fragments, and your cravings roar. That story is in my clinic every single day. Third, we stay humble and skeptical. I was trained, like many of you, to fear fat and to hand patients a one-size-fits-all solution. Eat less, move more, go low fat. I followed the script. Then I looked at my outcomes. People were not reversing their diabetes. They were collecting medication like souvenir shot glasses. That's when I started questioning everything, reading the trials with fresh eyes, and most importantly, changing what I did when the evidence and the results disagreed with the old dogma. That's not rebellion. That's being a good doctor. Fourth, a word to the person hearing this for the first time and feeling cynical. Please don't let cynicism disable your curiosity. Check the links I provided. Read the abstract. Look at the numbers. If your current approach isn't giving you the help you want or the patience you have if you're a clinician, give yourself permission to try something different for 30, 60, maybe even 90 days with your clinician's support. Be a scientist in your own body. Bring data back to your next appointment. Fifth, practical steps you can take starting tonight. If you're metabolically unwell, defined by a waistline expanding, blood pressure creeping, triglyceride high, HDL low, or your A1C climbing, prioritize removing added sugars and refined grains first. Build your plate around real food. Things like meat, eggs, fish, above ground vegetables if you're not carnivore like me. And the bulk of fats like butter, olive oil, coconut oil, avocado oil, and even better, the animal fats like beef tallow and lard. Many of my patients thrive by lowering carbs substantially. Some go keto, some go carnivore. The unifying principle isn't a hashtag. It's metabolic calm, stable glucose, lower insulin, reduced cravings, and better satiety. All those markers normalize. Your risk markers tend to follow. That's an outcomes first mindset. And for my clinicians, this is an invitation, not an indictment. We were all handed the same script, but our oath isn't a guideline. It's to a person in front of us. When RCTs don't show benefit for a universal saturated fat restriction rule, we should stop pretending that the rule is sacrosanct. Let's personalize care. Consider carbohydrate restriction as a therapeutic tool, particularly for type 2 diabetes, fatty liver, visceral adiposity, and high triglycerides. Watch what happens to A1C, triglycerides, HDL, medication burden, and patient quality of life. If your patients get better, you're practicing evidence-based medicine, not heresy. What about the inevitable pushback that you'll hear? But guidelines still say ... Remember, guidelines are slow. They lag behind evidence. And sometimes they lag behind outcomes we're watching in real time. You'll hear things like, but saturated fat raises LDL. Sometimes it does. The question is, what happens to the person? Triglycerides often fall, HDL rises, insulin drops, fatty liver improves, and the patient's lived experiences like energy, appetite control, sleep, all change for the better. When the total risk picture improves and RCTs don't show outcome benefits for blanket fat restriction, it's reasonable to prioritize metabolic healing over nutritional superstition. Now, I also want you to see the meta lessons hidden in the sugar story. If industry dollars could message a narrative in 1967, we should expect modern versions of the same. Food companies, pharma, influencer economics. None of us are immune to incentives. The antidote is disciplined skepticism and radical transparency. Read the methods, follow the money, measure what matters, and never be so wedded to macronutrient ideology that you ignore a patient's results. If you're a patient watching this, here's your homework. Pull your last labs and jot down 5 numbers: A1C, fasting glucose or CGM patterns, triglycerides, HDL, and a waist circumference. If you want to go deeper, track fasting insulin or a HOMA-IR. Then run a 30 to 90 day real food, low sugar, low refined carb experiment. Recheck the same numbers. Bring them to your clinician and have a grown-up conversation about results over rules. If you're a clinician, here's yours. Read the meta-analysis yourself. Ask whether your blanket saturated fat restrictions are improving hard outcomes or just checking a guideline box. Then decide if your patients deserve a more personalized, metabolically informed approach. I think they do. We were told a story. Today, the trials tell a different one. If what you're doing isn't working, you don't need permission to change. You need courage. Try the thing that actually moves outcomes, not just opinions. So if you found this video helpful, share it with a clinician who still believes the butter in your skillet is more dangerous than the sugar in your coffee. We can do better, and together we will.